Hopefully you can hear us all. Hopefully you can hear us. I'm going to go ahead and take you off speaker at the moment. Unmute you. And we do apologize for starting a bit late. That was my fault. There we go.
Good morning, everybody. This is David Mendelow in Newcastle.
David, good morning. It's Mario.
Hi, Mario. I'm with Akbar Hussain, my resident, who we hope will be trained after this webinar.
Excellent.
Okay. It looks like we still may have some folks signing in. I'm working with the screen here to delete or minimize what doesn't need to be shown so that you'll be able to see the, here we go, so you'll be able to see the slideshow. So bear with me a minute as I get that up and running. Okay, hopefully you can see the slides now.
Yes.
Okay, good. Okay, let me just give a couple of ground rules here and we'll get going. Dr. Zuccarello and I are sharing the screen, so what I will ask you all to do, he's going to speak for about 25 minutes, and at the end of that there will be time for questions. If you all have questions, we ask that you hold them. If you have issues, you can certainly write them in on the panel and we will address them at the end, but we cannot actually see the panel during the presentation. Excuse me. We'll keep you unmuted as long as you all promise to not type or talk or rustle papers, because those sounds are magnified tenfold during the webinar. Double click, there you go. Okay, and the other thing is, if you don't see, if you're attending and you see your name on the attendee listing, then please write your name in the chat box so that we know that you are attending. Okay, without further ado, here's Dr. Zuccarello.
Good morning and welcome. I'd like to particularly welcome our friends from Europe and also our friends from the United States. So this is the surgical perspective webinar, and let me move forward.
To the right. I don't know why it doesn't.
Why doesn't it advance? Okay, we had some difficulties advancing the slides. So the protocol overview is very similar to the protocol overview of MISTIE-II for whoever participated. You have a patient with the ICH, you need to screen the patient, make sure there's not an underlying pathology, then you need to demonstrate a clinical and neurological and radiological stability, and after that the patient can be then consented or randomized, and eventually if we go to surgery there will be the minimal invasive procedures we will describe later on. And the protocol called for 1 milligram of TPA every 8 hours for up to maximum 9 doses. So you can see on the bottom the flow chart. You have a diagnosis, you have a stability. We like to have as much as possible everybody to have an MRI. And then you have your dosing. The triangles represent the CAT scans. The stars will be the MRIs. And then you see also at the end will be the follow-up. Difficulty advancing. So the objectives of the presentation is to discuss briefly the results of MISTIE-II and the lessons learned from MISTIE-II, and then to present what we consider the 8 essential elements of MISTIE-III, which to some extent will represent the standardization of treatment, and then the procedure, and then some important consideration, particularly for the surgeons. Now, on MISTIE-II, what we found is, number one, is the minimal invasive procedure was able to reduce the clot size, not only safely and also effectively and efficiently. We didn't see any increase in morbidity and mortality compared to the medical arm. The reduction also in severity of the neurological, post-operative neurological status was quite significant. It was approximately 10 to 14% improvement across all the multiple modified ranking cut points. There was another caveat, which also was, if Dr. Mendeloff knows well, was shown that somehow also in the surgical trials that there is a decrease in cost, and also there is a shorter hospitalization of the patient treated with surgery. And finally, what we found that approximately 14% fewer patients went to a nursing home facility at the 6 months and 12 months of follow-up. So these are the key findings. The one thing which is of paramount importance is the catheter need to be placed in a nearly perfect position. And if it's not in a perfect position, we are not able to test the hypothesis that the removal of the clot will be beneficial to the patient. And so this need to be achieved through a proper catheter trajectory planning and a proper surgical review requirement, and then of course through a discussion with the surgical review committee, we can sometimes find cases where the site may disagree on the trajectory, but again, this can be settled, particularly for the site to show significant experience, then maybe they have a better ways. And so this is something that will be always part of our conversation. This diagram shows clearly that if you apply what we call the catheter placement score, which goes from 30 to 150, 150 is a perfect placement. If you have a placement of your catheter close to perfection, the residual clot size is very, very small. Whether this would translate in the future with better outcome, of course, will remain to be seen, but it clearly shows that the catheter need to be placed as perfect as possible to be able to reduce the clot size. So the procedure will be performed by certified neurosurgeons. So there is a mechanism in the study how to certify neurosurgeons. It will be performed most of the time in the operating room, although there are very few centers performing the procedure in a CAT scan suite or in an MRI. And there will be an introducer and then a catheter. There will be an aspiration of some of the clot at the time of placement of the catheter, and then we strongly suggest antibiotic coverage, at least all throughout the installation of TPA. As I said, there will be a certification, and each of you can read this slide and see which category it belongs to, and get pre-qualification, again qualification with probation and full qualifications. And without spending too much time on the slide, whoever is fully qualified can really qualify other surgeons. It can be the mentor, so to speak, of the other surgeons, or the instructor rather. So as you remember, I discussed briefly the standardization and the 8 essential elements. The 8 essential elements are very important because it allows us to conduct the study, which we believe will allow us to have a better understanding of the results. So there are 8 essential elements. One is to plan the approach. To plan the approach is to plan the entry point of your catheter. Then you need to choose a trajectory. The aspiration, the clot is at the end of a placement of your catheter, and you run the catheter or your cannula. Then the placement of the catheter to replace the cannula, and the assessment of the placement, which is done with a CAT scan at the end of the procedure. Then we require 6 hours of stabilization before the installation of TPA. And then at the end, depending if the surgical goal is already reached, we will discuss it toward the end of the webinar, the meaning of surgical goal, there'll be the removal of the catheter. And the removal of the catheter, just remind you, cannot be done before 24 hours after the last installation of TPA. There's some latitude which we will discuss. So this is again is a summary of what we said about the 8 essential elements: planning, trajectory, aspiration of the clot, catheter placement, assessment of the catheter placement, 6-hour stabilization, TPA, maximum up to 9 doses, can be less, and then removal of the catheter, which cannot be done before 24 hours from the last installation of TPA. So how to plan properly? We decided to arbitrarily to divide the ICH in 3 different categories. We call type A, B, and C, and I will give you examples of each type. In type A, you have a typical basal ganglia clot, and the basal ganglia clot is usually oval-shaped. And so the entry point that we thought was the best was the frontal, similar to supraorbital approach, and then the direction is straight into the clot, and you see the trajectory. The type B is a posterior basal ganglia, most thalamic type of ICH. We like to select a posterior entry point on the parieto-occipital area, and the trajectory is what you see on the right inferior corner. And again, the goal is to have this catheter placed into the clot, completely surrounded by clot, like Dr. Awad liked to call the sausage into the bun. So be completely surrounded, because that's the best way that TPA will act without having much of interference with the surrounding so-called normal tissue or maybe injury tissues. And type C is the lobar, the superficial. Your entry point is pretty much perpendicular to the major axis, and then your trajectory follow the entry point. As you can see again on the right inferior corner, you can see that the catheter is perfectly into the clot, in the middle of the clot, and this is what we like to see. Now this is the instructional surgical presentations, which will offend most of you, but I have to go through this slide. It's pretty simple. The protocol called for antibiotic, maybe NSAID unless there's any allergies. This will be given preoperatively and then every 8 hours following until catheter is removed, like I mentioned before. Skin incision, skin retraction, the borehole drilling, depending on the ICH type, the cannula introduction, and again, I use this cannula. Other people use a little bit different cannula. The meaning is not different. It is to try to perfectly place the cannula with a single pass into the central core of the hematoma, and I can just tell you now that 2 passes are allowed with a cannula, no more than 2 passes. Then usually with this type of cannula, I take the stylet, remove the hematoma until I feel that resistance is encountered, no more than that. We don't want to create and trigger more clots. And then the insertion of the catheter, removal of the cannula, and then the tunneling of the catheter. Very important is not shown in this slide, but the catheter has to be secured to the skin pretty early, because we have seen, unfortunately, some pullback of these catheters for gravity reasons. And so if you, at the end, that you secure the catheter, I think it will be safer than the closure, the 3-way stopcock, and the closed drainage system. As you can see, it's pretty standard. Not really anything particularly exotic. Consideration for the surgeons, there are several points which may trigger questions. Number 1, as we said, we have 8 essential elements. However, like we said, there's a little bit of latitude which is left. We have several surgeons which are extremely experienced surgeons, and they have their own technique. So some variability is accepted, and technical variation is okay as long as we maintain the standardization of the key elements, and the catheter is perfectly placed. So if you tell me that you disagree with my trajectory, but you put a catheter in a perfect position, I welcome your suggestions. If you don't want to use that cannula, use a different cannula, and that perfectly okay as long as we respected, the essential elements. The image guidance is mandatory, and differently from MISTIE-II, we allow, along with the neural navigation, also the real-time image guidance, CAT scan and MRI. As I said at the beginning, very few centers are using the CT scan guidance or the MRI, but it's welcome if you want to use it. Because of course, there are some differences between the two. There are two algorithms for catheter placement, which differ slightly, but they differ from each other. If you use the neural navigation, usually you use a larger hole because you will introduce your cannula and then the catheter, and then, if you need to reposition, of course you need to go to the CAT scan, check the placement of your catheter, go back to the OR, retarget, and replace your catheter if it's not properly placed. If you're working the real-time CAT scan, you may just use a twist drill. You can use a small dandy needle, and then you can retarget because, of course, it's real-time CAT scan, and then you place your catheter rather than a cannula, and then not more than 2 passes usually are allowed, and then the reposition is pretty obvious. You have a CAT scan, so if you see that it's not in perfect position, you can pull the catheter or readjust accordingly. So the CAT scan allows more flexibility because you have real-time imaging versus the neural navigation. The accuracy of the trajectory, it's very important, and the more of course cases we have in a study, the more we learn. And what we have seen in some of the cases, not only MISTIE-III but also MISTIE-II with not the same problem, that there have been some difficulties in targeting even relatively speaking large clots. And so we went through a brainstorming why this happens. Of course, all the surgeons are very experienced surgeons, so it's not because of lack of experience. There must be sometimes some technical issues. And so, first of all, the recommendations are, if you use a CAT scan, and my experience is mostly with BrainLab, but I'm sure this is similar with other systems. If you use a CAT scan as images for your neural navigation, you need to use the same protocol used for the MRI. I'm sure all of you are very familiar with a protocol for neural navigation. If you use the MRI, you have approximately 256 or 260 slides approximately. If you use a CAT scan, very frequently you have a fewer number of slices. This may lead to inaccuracy in the placement of the catheter. So you need to try to use this a similar protocol with a 1 millimeter slices. Particularly, what we have seen is also that if you use a neural navigation, if you use fiducials, if you are targeting a posteriorly located clot, if you don't use the fiducials also posteriorly, the accuracy of the placement of your catheter goes down significantly. And I don't need to explain to you because you know perfectly what I'm talking about. So you need to use the number of fiducials which are not only covering the frontal and the temporal side, but you need to use fiducial also on the posterior part of the skull. And it is particularly critical, again, for type B when we target, the entry point is parietal, parietal occipital, and the trajectory is posterior trajectory. So this is our things that I'm sure 99% of you know very well, but we have encountered these difficulties, particularly for type B clots. I think we have pretty much discussed this because the reiteration most difficult is the catheter medial to the clot, the location that I think I covered most of these issues. And you can see a typical example of trajectory B for a clot located more posteriorly, and you can see that very frequently this clot are missed medially, and we believe is because the center has used a CAT scan as in neuronavigational images, and the number of fiducials were not posteriorly located, so the accuracy, which on the planning, which we receive as a center, appear to be absolutely spot perfect in the center of the clot, but then the catheter is not in the center of the clot. And so that's why we think that there are some technical errors. Going to the end of the webinar, there are two issues. One is the repositioning / replacement of the catheter before dosing, and repositioning or replacement of the catheter after dosing, which means after you already started the installation of TPA. So if you need to reposition the catheter before dosing, the most typical is the pullback. And in fact, I always suggest people to target the clot rather deeper than more superficial, because if it's deeper, it's really not a problem. You can pull back that usually a few millimeters up to centimeters, you're in a perfect position. However, you can remove the catheter and replace using a second minimally invasive procedure if you think that the placement of the catheter is inappropriate, not enough and not good enough for the removal of the clot. So complete replacement of the catheter is allowed no more than one more time, so 2 times at the most, because we don't want to have the cannula replaced more than twice to avoid any possible bleedings in a tract, which we have seen, unfortunately. So if after placement of your catheter, you feel that you need to reposition, you don't need to send all your images to the surgical center. After you have final placement, then you collect all your images and then send to the surgical center. So when you feel that you have the final position. Now, the reposition or replacement after dosing is slightly different, because if the dosing has begun, of course we have TPA in the field, in the area. So we need to wait 24 hours before we manipulate the catheter. So if you want to replace the catheter because the catheter now, after the installation of TPA, has removed great deal of the clot, but you want to do better, then you need to wait 24 hours. You pull the catheter, you go through the same spiel that you did before, to the same protocol, and then you replace the catheter, you wait 6 hours for stability, and then you resume the dosing. So that's, I hope, is clear. Then essentially it's a time, the difference is time. You cannot manipulate the catheter before 24 hours. And then after you manipulate the catheter after 24 hours, you have practically the same like it was the first time. Okay. So if you have a difficult shapes, we allow more than one catheter, but I will ask you always to discuss with the surgical center and not to use 2 different trajectories and 2 catheters, but this is allowed, and we have discussed it many times in our surgery center committee meetings, that if you have to put 2 catheters because of very large clots, you leave maybe the 2 catheters in place, because sometimes you can use one catheter versus the other one to instill TPA depending on how much clot you remove. But these are issues which really can be covered only on a case-by-case basis. It needs to be discussed with the surgery center very actively. IVH. IVH, for whoever participated in MISTIE-II, IVH was not allowed, but now we don't consider IVH an exclusionary criteria. So we would like to include the patient with an IVH. However, cases with IVH need to be discussed and adjudicated with the surgical center. The case with IVH and more than one EVD catheter cannot be included. Very important, if you have an IVH catheter, if you have an ICH catheter, so 2 catheters, please label the 2 correctly, because unfortunately it can happen, and not to know exactly which one is which, and to inject the TPA in the IVH in the ventricles would be violation of the protocol, because of course we are not treating blood in the ventricle, but blood in the parenchyma. So need to be marketed properly, and that is quite important, because unfortunately it has happened. These are some CPT code, particularly for the United States, and the surgical endpoint, as I mentioned at the very beginning, is to try to decrease the clot volume between 10 and 15 cubic centimeters. This came from the analysis that we had in the MISTIE-II, where the 10 to 15 cubic centimeter was associated with the best outcome. And we know, of course, from many other studies, epidemiological studies, that the larger the clot, the worse is the outcome. But in this study, we try to have between 10 and 15 as a goal for our surgical endpoint. And essentially, it's impossible to have all patients reaching 10 to 15 cubic centimeter as a surgical endpoint. In some cases, the surgeon does not feel comfortable to continue TPA. So this has to be also sometimes at the discretion of the surgeon, who is responsible of the patient and his well-being. So in some cases, you need to individualize the goal depending on the condition and situation. But ideally, this is what we want. We don't want to leave more than 10, 15 cubic centimeter in any patient's brain. And with this, I welcome all of you to MISTIE-III. We have been extremely excited about this study. We have many centers participating. Our accrual of a patient enrollment and the patients seem to be really excellent, and we really hope that this will provide another way for our patients to overcome this extremely, of course, disabling disease like intracerebral hemorrhages. So thank you, and if you have any questions, please go and ask them. And before you start asking questions, Lynn will provide you with her cell phone number. My cell phone number, if you want to discuss any issues, is area code 513-646-8311. And Lynn will give it to you again later. But I will be happy to discuss any question offline if you need to do that.
Thank you, Mario. Could you just repeat your cell phone number for us?
Yes, and if you call from UK, of course, you need to put the country code, which I believe is 001, if I remember correctly.
That's right.
001 513-646-8311.
Thank you, Mario.
You're welcome.
And do we have any questions?
I have one question. Hello?
Yes, sure. Dr. Gupta?
Yes, I'm here.
Yes.
No, I'm good.
Oh.
Hello?
Yep, I'm good.
Okay.
The person that has a question, go ahead.
My name is Fong Chen. I'm calling from St. Louis with St. Anthony Medical Center. So we have been, maybe I'm not really related to your talk. So we have seen over 50 patients. So far, we have not recruited any patients for the study. The reason for that is always this patient did not meet the required criteria.
Okay.
One of the main reasons is we always find the clot. Some patients are very good at the other criteria are well met, but one of them is the size of the clot. Remember, 3 of them is the clot is between 20 and 30 cc's. So ultimately, we had to rule out this patient. So do you still think the volume of the hematoma has to be greater than 30 cc's?
Yes, sir. Dr. Chen, this is what we decided, and I don't think we can change the volume at this point. So any clot smaller than 30 cc's will not be included. Some of those clots open into the ventricles, and so those patients could be part of the CLEAR study, which allows clots smaller than 30 cc with intraventricular extension to be enrolled. So
yeah, we did have a few patients like that. I thought maybe might need a ventriculostomy, so we have to exclude this patient.
Yes. I'm sorry.
Thank you.
Any other questions? I do have one other item to review. If you could just hold on just a moment. We've had a request from some other folks to briefly review some of the perioperative surgical center interactions that happen. You know, right at the time, there's a lot of things that happen when you take a patient to surgery. And there's a lot of things going on, and generally what happens, the surgical center coordinator, I'm with the Cincinnati team, and there's folks with the Chicago team. We work with your site coordinator and guide them on the spot. But again, some of your colleagues have suggested that we briefly discuss in this form some of the steps that happen. So that's what I am prepared to do now, just to tell you the sequence of what happens. And we're getting a lot of background noise here. So I don't want other people to not be able to hear what I'm saying. So if you could hold some of your side conversations. What I'm suggesting here is that again, as Dr. Zuccarello mentioned, the process of surgical planning starts early, and as he mentioned, with the fiducials, that you want to get that early. In fact, we suggest that as early as that 6-hour stability scan, you want to get the fiducials, especially if the patient looks like they're going to be a good candidate. So you've got that on board. And then, of course, the next step in this process is the site declares the type of clot, that A, B, or C general trajectory. That's inputted in the EDC. And then once you're about ready to take the patient to surgery, and in fact, most of you have your brain neuro navigation equipment in the OR. So this is where things start to happen real quickly. You load those most recent images into the neuro navigation equipment, register the patient, and you need to do that as soon as possible once the patient arrives in the OR. And then usually it's the coordinator, but someone that's part of the team in there will use their cell phone and take a picture of that neuronavigation screen that shows the planned trajectory, showing the coronal, axial, sagittal views of the trajectory, literal trajectory of how the clot is to be targeted. Then that image is sent to the surgical center coordinator. That could be sent via cell phone, to cell phone or cell phone to email. Eventually it's uploaded into the EDC, but that can wait until a little bit later because we know that time is critical. And then what happens, myself, the coordinator, I send that image on to, in my case here, to Dr. Zuccarello. And he reviews that as soon as possible because we know the clock is ticking. You're in the OR and you're eating up OR time and dollars. So he reviews that planning as soon as possible. He gives feedback to the surgeon, either directly by talking with the surgeon, or if everything looks fine with Dr. Zuccarello, he'll tell me that's fine, and I get back to the coordinator or direct to the surgeon, however it's all set up. And or if the surgeon is, say, pre-qualified and needs to have the telementoring, then Dr. Zuccarello would call direct to the surgeon in the OR and discuss the planning. And so that's how it happens. So, a lot of things are happening very quickly. The final thing I wanted to mention, that there is a requirement to document acknowledgement of all of this feedback of concurrence with the trajectory plan on our end and acknowledgement on the surgeon's end before the surgery begins. Well, we know that that's not practical to get into the EDC and acknowledge that. So what we suggest is that, and I tell the coordinators to note the time that this concurrence and discussion occurred so it can be annotated as a late entry in the EDC. So are there any questions about that? No, doesn't sound like it. Okay, well, hopefully that was helpful. Okay, so you'll have Dr. Zuccarello's number, and I will give you mine, and that is 513-340-3965. And if there are no further questions, we will go ahead and conclude the webinar. Okay. Great. We thank you very much for your attendance. Bye-bye now.